There we go. I think everyone's with us now. So let me start. Good evening, everybody. Hello. Nice to see you all. Thank you for joining us this evening. My name is Steve Sheldon from CelticSMR MSK. In a moment, I'll hand you over to Adrian, who's going to take us through scanning the knee this evening, delighted to say. So before I do that, lovely to see you all. Thank you for joining us, as I say. One or two familiar faces, always great to see you, and some new names and faces I'm seeing come up on the screen there. So that's great. Always nice to make new friends. So thank you for joining us, as I say. If I could ask you to stay on mute, we'd be very grateful. Thank you. If you do have any questions, all questions are welcome. Drop them on chat, and I'll interject as we go along with the questions for Adrian. As I say, Adrian's doing the scanning this evening, assisted by Abid, whose knee we are going to critique. And so great to see the guys. It's great to see you again this evening, Adrian and Abid. Good evening. How are you?
Good evening, guys. Very well, thanks.
Hello, Steve. Hello, everybody. Good to meet you all. Thanks for joining on this sunny day. It's probably rather be sitting outside in the garden, but thanks for joining so much. Appreciate it.
Good commitment from people this evening to be joining us on an evening like tonight. So yeah, great, good stuff. So yeah, if I've got any questions, Adrian, I'll jump in, but otherwise over to you, my friend.
No worries. Yeah, good evening, everybody. Thanks for joining us. So yeah, as Steve said, we're going to be looking at the knee. So what I'll do is I'll go through a few basic things to do with the probe and how to hold the probe and how you position it on things you look at on the screen. And then we'll get into the scanning. We'll probably cover a little bit of the anterior, a little bit of medial, lateral, and then if time looks at the posterior as well. So let's first of all grab the probe. The camera. So the first thing we need to do is what I do is to try and orientate myself round on the screen. So what I do is I just touch the end of the probe. And can you see on the image, also image, where my finger is there? So that's orientated. So that part of the probe corresponds to actually where that is on the screen. So I actually want, when I'm scanning this on Abid's knee, I want the top of the screen to be on the left of the screen. So if you look, if I just touch just have the top bit touching, not the bottom bit's all there. You can see I'll get a little bit of an image on that top bit, so that's where I want to be. Okay, and then if I connect the bottom bit, I get the bottom bit. Okay, top bit, bottom bit. So that orientates me on the screen there. And obviously, when I move up the patient, I want it to be sort of moving towards the left on the screen. That's conventional. That's what you do in sonography normally. And to be honest, it makes sense because as I move up, as I'm moving the probe this proximally, then the image is moving on the screen how I like it. And as I go down, I know that I'm going down the leg that way. The image is going the opposite way. So that orientates me. If I turn it round, and you'll see as I go up the leg, it confuses me straight away because I see all my images going the wrong way. So that doesn't feel right to me. So I automatically know to turn it around. And as you get to scan, you'll get to feel what feels right and what feels wrong. So I usually start. Let's start with holding the probe. So you see a lot of people holding it like this or up here like this and doing this sort of thing. The only problem with this is you haven't got much control of the probe. So if I'm on here, I just haven't got much control of the probe. It's slipping on and off. So what you have to do is you have to come right down to the probe head like this. And I use these two fingers here as like a standoff. So that is in contact with the patient all the time. Now I've got complete control of the probe. Okay, and it's only the thumb really that's holding the probe, and the fingers are basically resting on Abid's leg and guiding guiding the probe. And that way I can keep it relatively straight as well. I'm not moving off to the side. Okay, let's crack on. So when I start a knee, I tend to, it depends what comes in on the question of what the problem is in the knee. If it's something at the back of the knee, then I tend to focus at the back. If it's something medial or lateral, then I'd focus on those points. But we'll go through it all, so you know what to do. But I wouldn't necessarily do a full knee exam on something that I can sort of pinpoint the location as such. So I start in this position, so the knee bent. Okay, so that puts the tendons on a little bit of tension. So when I put my probe on there, you can see that the patellar tendon is nice and straight and uniform on the screen. The little red dot, I can move up. Oops, that's the wrong way. Okay, so that's your focus. So that's focusing the beam at that level. That's where you get most of your quality image at the focal point. Okay. Now I can probably come down in the depth a little bit. Maybe. There we go. That's probably a little bit better. And now that's pushing the focus out of the way. There we go. So that's a good starting point for the patellar tendon. Okay. So I can see nice fibular pattern of the patellar tendon. Okay. Can't quite get it all in one screen, so I'll go up to the patella, have a look at the sort of insertion, if you like, as it goes over the patella. Okay.
What's that little dark patch just under your cursor there? Is that a little tear or something?
Well, this is commonly where you get sort of jumper's knee. So you have to sort of interrogate this quite well. What's actually happened is that the way the fibres are sort of attaching, it's sort of giving you the impression that it's tendinopathic. But what you need to do is sort of just angle up and in, and if you can see that I'm brightening those up now. Okay, so I think that's pretty okay. If you're still unsure, then the thing to do is to pop the Doppler on. Okay, which is the BDI. Okay, so I put that there, and then if you look on the left here, you've got the PRF, which is 0.8. So that's quite it's quite low, which is probably why I'm getting all these artifacts here. So let's see if I went up on the scale, just gets rid of a few of those. But you want it to be sensitive enough to pick stuff up. So what you can do is you can find a little adjacent vessel if you like. Just get the Doppler signal so it's just showing, and then that's your sort of optimized area, and then come back to this area. So nothing much going on there. You have to keep a steady hand, and obviously when you move, you will get a lot of artifacts. Okay, so if you look at the anatomy image, so what we're doing is we're just interrogating this here, this patellar tendon here, and you can see it's all continuous. So sometimes this is called a patellar ligament, if you like, because it's not strictly bone to bone. It's sort of like one continuous sort of tendon, if you like, from here down. So yeah, so you can interrogate this here, and obviously down to the tibial tuberosity here, which we're going to do now. So there you go. There's the patella. Just go back here. Okay, so patella coming down to the tibial tuberosity here. Very nice, very smooth tibial tuberosity. Looking along here. Very nice. No osteophytes, no adhesophytes. Tendon looks nice. Again, you can pop the Doppler on there. Okay. This is commonly called Hoffer's fat pad, so you can put the Doppler on here. There's any sort of hyperemia here. It's all quite dark there, doesn't it? Do you get any issues with the patellar tendon? No. No, so it's probably just angle there. But the other thing you can do is obviously go transverse. Okay. and then try and you've got a better angle with transverse because you're not going to stitch on the bone with a longitudinal. So I can come up here and I can see that's nice and bright onto the bone there, so that's fine. And as you go down, you can see it's a nice broad tendon. Okay, so that's why you can't just interrogate it in a long section, because you've got to scan out to the side, so go all the way out to the side and all the way back this way as well. The fibers look a little bit dark there as well. I'm just bending there to try and brighten those up.
So it just shows how essential it is to have good manipulation skills with the pro, because sometimes I end up seeing that's not really there through artifacts.
Yeah, it'll throw you a curveball all the time. An isotropy it's called. So you can see as I'm going down this tendon, if I angle, I can make that tendon look really dark. So if you look at my pro position, I'm angling down. So what you need is the beam at 90 degrees to the tendon. That's bright. Then if I go off the other way, angle too high, then it goes dark again. So you can say, oh gosh, I've got a really tendinopathic tendon here. It's really dark, but it's just the angle. If you're angling and it's still dark and it's not going bright, then obviously you might have a tendinopathic tendon, so just be aware of that. And you follow that down in transverse all the way down to the emphysis.
So transverse essentially gives you a cross section then.
Yeah, so this is like, it's probably nice. It's nice to start in transverse. It gives you an overview.
We've got to really look at the internal structure more than the longitudinal.
Yeah.
And within the main body of the patellar tendon, do you tend to see the intrasubstance tears? Have you come across any of those? Or
I haven't come across many, to be fair. But basically an intrasubstance tear would just look like a little black hole in this orientation, or in this orientation it might look like a longitudinal sort of split hole.
Is it compressible?
Yes, it can. Yeah, you will be expect, unless it's got a layer of blood in it or anything like that. It should still be compressible though. But
how can you tell the difference between a cystic lesion and a tear? Is there a subtle difference, or is it quite obvious?
Well, if it's a cyst, then obviously there won't be much compressibility. So a bit like a ganglion, it's quite full of quite viscous fluid. So yeah, you compress, but if it's not collapsing, then you've got a little cyst. I haven't seen many of those, to be honest. Okay, so that's essentially the patellar tendon. So another word warning: when you actually are interrogating the patellar tendon Doppler-wise, it's a good idea to just get the patient just to stretch out their leg a little bit. That takes off pressure off that tendon. Obviously, it's going to look really tendinopathic, but it'll give you a chance to put the Doppler on and just see if there's any sort of mild neovascularization to that tendon. Okay, or even probably just not so much. Yeah. So if the tendon's on too much tension, obviously you'll compress those little vessels and you won't get any Doppler signal.
34 degrees.
Yeah, that's about right. Okay, so here we go with the quadriceps. Now on the top, so I've basically just gone from patella over the top, and if you look, you can probably just see a very dark line going all the way over the top and continuous with the quadriceps tendon here. So a very common place to get calcification, obviously points here, or the easier points, I should say. Here, calcification, things like that.
So things out to what, a millimetre or two as it passes over the patella itself?
Yeah, ever so tiny.
And then do you expect the quadriceps component to be thicker than the patellar insert, or is it more or less the same thickness and diameter?
I think to be honest, it seems to be thicker, but I don't tend to, unless it's, it looks very abnormally thick, and I tend to look at this tendon here and say, right, is there any sort of sticking into that tendon. And then look at this one as well. But this one you see is made up of obviously the quadriceps. So you've got a lot going on here. So you've got rectus femoris being the sort of top layer, and then you've got vastus intermedius and lateralis being the sort of intermediate layer, middle layer, and then intermedius being the most deep layer. So you've got all those layers there. You can probably just about make them out there. So you've got one layer there, the combined layer there, and then the intermedius there. Okay.
Do you ever try to dynamically stress or see the tendon?
I would do if there was, a suggestion of a little tear or something, because, dynamically, and just see that potential gapping in the tendon and opposing movements where the tendon will oppose movements if you've got a little tear under a dynamic strain.
Just trying to tense my quads for you so you can see. My quads are not great, so.
Yeah, and you can see there's a little bit of fluid here. A little bit of fluid's normal. If it starts coming back and forming a big puddle sort of over here, then that's probably a bit more abnormal. Last time we spoke about the knee, someone mentioned about whether you can see a flicker. Yeah, only really if you've got a bit of fluid, really. I've got a picture of one of those later anyway. If you've got a nice big puddle of fluid, then you can probably see a flicker coming across. So that's, so quadriceps. So now, if you go to the anatomy again, you see how high rec fem is as a tendon. So medialis and lateralis, their muscle comes down quite low, whereas rec fem is quite high. And you'll see this on this scan. So if I go, I've got this profile here. Okay, so if I go to the medial side, you'll see medialis here, muscle belly, medialis. Okay, and then you've got lateralis. Yeah. Okay, I'll just bring that focus there a bit. Okay.
What's changing the focus for you to see better?
Yeah, so so I'm just moving that little red triangle you see at the side of the image. That's where the beam is focused. If I go up and down, you can see how the beam changes.
Awesome, yeah.
And if I go down, oops. Yeah, so this is the medialis and lateralis. If I go up, I'm here now. Look how far I'm up the leg. Well, let me just move that. Look how far I'm at the leg, and now I'm hitting rec fem, which is this muscle here. Okay, so it's coming down. Now it's tendon. So you can see how far I am before you reach muscle belly and tendon here. So now just decrease the depth.
And we're in transverse section here, so we can see the body and the bulk of the muscle.
Yeah, so you've got rec.
And I suppose you can see a wider view of the more in clarity. We'll see.
Yeah, so you've got a trapezoid function on this machine. So if you click trapezoid, it just opens out the size of it, just to give you that little bit more of sort of panoramic sort of appearance, just if you want to just give you a little bit more field of view. So you've got intermedius at the bottom there, and then rec fem. As I go down into rec fem tendon, then I'm already in muscle belly of medialis and lateralis. Okay. If you follow this if you follow this tendon down, as I'm going down transverse, here it is, just that bit there. Now, if I turn long section, you see that that makes up the upper border of tendon here, so that's rect fem. Okay.
So you want to see nice fibres within the tendon. You don't want to see too much dark.
It almost comes down. Well, it does come down the bottom here. So the tendon's formed at the inferior aspect of that rect fem. Then the inferior aspect of that muscle becomes the superior aspect of the tendon. If I go long section now, there you go.
Fabulous detail.
Got obviously the little components of medialis and lateralis and then intermedius. Inferior there. That is of the parts. Now, the other thing that I look for is something called the prepatellar bursa, sometimes called a handmaid's knee. And for that, right on top of the kneecap here, and I'm going to do this. Now, I'm just going to freeze the image here a second. Okay, so what I've done here is I've got a standoff of gel. Okay, I've got some gel here, and I've got some gel here. Okay, so when I see that, if I was looking at this, looking at someone's image, and they're looking for prepatellar bursa, I can look at this and say, right, he's got a standoff of gel there, standoff of gel there, and no, he's not. I know he's got no pressure on that at all. So there's no bursa. Okay. If I was to see this and I didn't see these standoffs of gel, I'd be, is it just pressing too hard? Or, could there be a bursa there? Because you will squash it so easily. So if it's like this, a little bit there, but you can see that just a little bit of pressure, you could potentially squash that. But it's quite tender anyway. They scream at you if you press any harder. But if you've got a good standoff of gel either side, and there's no bursa there. I'm going backwards and forwards here, side to side. And I'm not actually. There's no pressure on your leg, is there?
No.
The only pressure is probably my fingers on the side of the probe holding. So I'm basically just gliding through the gel on top of the knee, and not essentially touching the knee with the probe at all. And now I can be confident that there's no prepatellar bursa. So there is a bursa down. You get bursas down here as well. One here, even we can get one here as well. So we can put a few pockets of fluid there as well.
Or fluid appears so dark or bright.
So black. So we call it anechoic. So whenever you see, you've got to be careful, obviously, because you can get sort of fluid that's hyperechoic, and that might be a hemarthrosis. So if you see that, so if you saw that in the elbow or something, automatically I start looking for a fracture. So the radial head or something like that, because it gets into that little recess, you get a bit of fluid, and if it's hazy fluid, it's a hemarthrosis, and that then you start thinking, what's going on here? Okay, so that's sort of like the anterior aspect of the knee. So let's have a look at the lateral side now. So for the lateral knee, let's bring this. That's medial. So here's a lateral knee here. It's all a bit complicated. Let's take some. Where's the muscle? There you go. take some off. So I look for the joint space, and I look for the lateral collateral ligament, a little bit of the meniscus, the ITB, which we come off here. That's good. It's tubercle, and then obviously the collateral ligament will come off the fibula, and then biceps will be coming off the fibula, but going posterior. We'll have a look at that as well. And then there's a little way you can remember this. I tend to remember it as a backwards Zorro. You know Zorro, the chap with the sword. That yeah. Steve's giving me a little smile there. You get a little backwards Z, if you like, and that's your Zorro picture. And the first bit of the Z being the ITB, and then the backward bit being the collateral ligament, and then obviously the biceps femoris going the other way. So let's have a look at that. So I'll probably put a little bend on again. Let's go back. Okay. So this is quite a nice little landmark. This is where your popliteal fossa is. You get the popliteus fossa, sorry, you get the little popliteus tendon in that little groove there. And I just come a little bit further down. I've got the lateral joint here. Okay. And check a little bit. And then focus up. Focus down. So you can't use ultrasound to rule out meniscal tears, but you could probably, if you're looking for one, you might see one. And basically looking for like a defect through the meniscus. Yeah, it'd be like a little vertical fissure, if you like, through this meniscus here. But obviously you're only looking at the medial lateral walls of the meniscus here, not looking at the whole meniscus.
Adrian?
Yeah.
Can I just had a question from Chris. Hi, Chris. Always good to see you. Thanks for joining us. Hi, Adrian. I assume calcific lumps within the bursa are easy to image.
Yeah. So if you get a calcific lump in the bursa, it'll basically just like you'll see the initial white border of the calcification, and then there'll just be a shadowing behind it, because obviously the ultrasound can't pass through the calcium. So you'll see a little halo of bright heterogeneity, and then a strong sort of shadow behind it. It might not be shadowing actually. It might be just a bit of soft calcification. And within fluid or bursa, they stick out like a mile. Yeah.
Thank you.
That answers your question, Chris.
I'll let Chris come back if not.
Just on so here's the lateral joint here, and if you just look to the side here, you've got this sort of attachment here, and this is actually the ITB, the iliotibial band. So if I elongate that out, I can follow that. Okay, so it goes over. I can follow that. Pretty much in it, obviously it goes all the way up to the crest there. So you can follow that. And the place to look is about here. This is where you get sort of the ITB syndrome, or just thickened and heterogeneous, and you can sort of dynamically assess that. Might cause pain over this area as well. So that's the ITB. Okay. Now for the lateral ligament, was that okay? Was that answered, Steve? Is that all right?
I think so. Not heard back from Chris otherwise.
So this is now. I'm now on the fibular head here, and I'm looking at this dark line here. Okay, and I'm going to obviously point that back towards the femoral condyle here, and you can see it takes a little dip here, and then comes up and attaches here. Now that's the collateral ligament. Now it's not under stress here, so that's why you can see it all dark. Okay, it's not under tension, but that is, it's quite a long ligament. So that's it there. Okay, now if you do want to see this under tension, I'm going to put this leg down, and then you can just rest the leg like that. It puts a little bit of tension, so you have to sort of find your thing again. And there's it gone. There, okay. And that puts a little bit more tension on that ligament. You can see it's a bit more straighter now. I'm just trying to keep a steady hand doing this. So there we go. There we go. Oops. There. So it's coming across now. It's a bit more under tension. You can see it a bit more.
Not bowing as much now, is it?
No, it's not bowing. Okay. And then obviously,
Rarest stress on.
yeah. Then you can go back to the fibula again. And I go back. And then I'm on the biceps. You know it's biceps always because I'm just going into the muscle belly here. Okay, so that's your, if you go back here, so that's your zorro, if you like. So it's thing, backwards Z. Yeah, so just remember that. Biceps yours to the fibula, fibula to the condyle, and then obviously the FXB and the Gurney's tubercle. So just think of your zorro. Right, so let's have a look at the medial. And I come across to the medial here. Nice, lovely joint space. Okay.
How are you orientating stuff? Are you going off the tubercle, or is that?
Well,
knowledge of anatomy is where you should be going.
if you look at the bottom of the kneecap and just come round and just plonk your transducer in the middle, you're not far off. So the bottom of the kneecap comes straight down. And then you should find this joint space actually read, and then it's just kind of just adjusting a little bit, so I can just see the meniscus here. I can interrogate that, and then you can do what you do with the shoulder. Just take the frequency down a little bit and see if you can just penetrate a little bit more down here. It's not so good for this, but certainly in the shoulder you can do this with the ACJ down deeper. Just don't forget that's open to you as well. Okay, so we've got the medial collateral. Okay, there's actually three components to the medial collateral. You've got this superficial component that runs along the top there. You've got this deep component which runs to the meniscus. You've got like a femoral meniscal component. And then you've also got a very, very tiny tibial meniscal component here that obviously tend to just see this one mainly across the top here. We'll follow that down. It's a very long component, this one. So here you can see this dip. And then that's roughly where the medial collateral ligament will insert here. And that brings you nicely onto the pes anserine. Okay, so it's quite difficult to see because there's the three components to the pes anserine, which are sort of sargents. We've got sartorius, gracilis, and semitendinosus. they're here. And they sit on top of this sort of medial collateral ligament here. So if I come more anterior, see them. I don't know if you can make them out at all. They're quite. Let me just try and use anisotropy. Try and help you. So there's one. There's another. So you can use anisotropy to help you just by altering the angle of the probe, and they'll just flash a sort of tendon architecture at you. So they're here, one there, and there, and there. Okay, and that's your pes hamstring. There's no pes hamstring bursa. There's a bursa that they highlight even more. You know what you can do? You can just go on one and angle back. You know that they obviously go back towards the back. You can see them coming over here. I'm not quite sure which one this is at the moment. I'll have to go back and interrogate it. There's one, and if I go behind, I can actually follow that behind. And follow it back onto the biceps ring. You can do that with each one if you wanted to interrogate each one. That's the medial. Any more questions, Steve?
Not at the moment, no. But, prompt everyone out there. Any questions? All questions welcome. So please do fire away.
Just thinking,
That's the thing.
if there are any questions just before I go to the posterior aspect of turn, I'll be over. That's all.
Okey coke.
So what we've got over? We've got over quadriceps, the bursas, prepatellar bursa, patellar bursa at the top here. We've done the patellar tendon. This is where you get osteostratus in children. You just see a very sort of bony prominence here. It's maybe just pulled off a little bit. So that's always something to look at for.
Not a regular sort of appearance.
Yeah.
The growth plate thing as well, though, isn't it?
Yeah. So there's that. You can see this is
Looks like calcification.
yeah, it does. Yeah. And then we went over the lateral. So we looked at the lateral meniscus, looking at components of this obviously this is popliteus tendon, it's in transverse here. Medial meniscus, the ITB at the top there, and then we looked at the sort of backward zorro for the ITB, collateral ligament, and the cross, and then the biceps femoris going back that way. And then we went onto the medial aspect, looking at the meniscus and the medial collateral ligaments, and it's three main components: superficial, the femoral meniscal component, and the tibial meniscal component. So when you're looking for meniscal things, you know, look for how this meniscus is behaving. Is it protruding out? Is it bulging out? Is it causing that lateral ligament to bulge up? All things to account for. Get quite a lot of cortical irregularity here to account for. Goes on serene. So this is the medial collateral ligament. Comes all the way down here. So it's almost down into this lower upper sort of shin area here. And then that's where the pes anterior is, just up that dip. And then you can interrogate that. Okay. You can pick out the sort of retinaculums as well, but they tend to be more prominent if there's an injury or if there's things going on. So banded tissue. Okay, so maybe we can have a look at the posterior aspects.
Sure.
We really want to
Yeah.
write it down.
Let's flip over for you.
Okay. Oh, I haven't been doing my anatomy right. So now we're going over onto the back. Okay. So the main thing that come in with knees, me as things like Baker's cysts, usually. So that's the sort of first thing I rule out. And the way to do that is to find your what we call it. I call it the cherry on the cake, basically, which is basically your semi-tendinosis tendon on the cake of semi-membranosus. Okay. And then I follow semi-tendinosis, semi-membranosis, and then I follow that down until I reach the medial compartment. And then all of a sudden, obviously, tendinosis goes up. You'll see medial head gastroc here. And then this is the tendon of semi-membranosus. And it's this area here where you get this protrusion of fluid, the Baker's cyst. Okay, so there's the medial of the gastroc. So this is that speech bubble that you need to look for. And that is what you must find in order to, be more confident that this is a Baker's cyst rather than a soft tissue sarcoma or something. Obviously, a Doppler interrogation is one thing, but you may get a little bit of Doppler appearance within the Baker's cyst anyway. So you're looking for this sort of speech bubble appearance here. And it's always on the medial aspect of the knee. So again, follow that up. Semi-tendinosis, semi-membranosis, and this semi-membranosis comes into the tendon here. I just angle that, see that, and then obviously that's medial head of gastroc. So it's between these two, perfect there. See, and that's where you get it come up through there. And then, if I don't see a Baker's cyst, then I'll just have a look at the back of the joint here. So you can see how I'm not getting much information down here. So what I'll do is I'll bring my focus down. That helps a little bit. And I'll even take my frequency down. Okay, and that gets me more. So I'm now down to 8.5, and I can see right at the deep now at the back here. Okay, you can see a nice cartilage thing here. Actually, there's another thing I'll show you on the anterior, but we'll do that after. Yeah, and then obviously the tibia here. So this is where semi-membranosus comes in, actually. Semi-membranosus. So you can interrogate a knee joint there, or even on the lateral aspect, or the joint on the lateral aspect. Yeah. Interrogate that. Now the other thing you want to rule out is obviously the BBT. Now this is an escaping, but it's worth covering anyway. Because it's worth looking at if you've got a large Baker's cyst. You'd want to rule out the DVT as well. Obviously that can press on the vessels. There you come. So the way I remember it is, obviously this is called the popliteal fossa. So there's a little mnemonic you can remember. It's when you're in the pop, the veins on top. So it's a good way to remember when you're in the pop, the veins on top, and it will also compress as well. And then that's the artery. On top is the vein. Okay, so you can go down and you can press depth a little bit. So it's the vein, press, 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 press. And you can follow that down into the calf and sorts of things like that. So, and then you can pop the one. And put the colour on. You can change the scale because that's probably a little bit over. Stop. There we go. There we go. And then what I do is I squeeze the calf. So as I'm squeezing the calf, you get that sort of augmentation of the vein. And you can sort of almost say, right, that must be painting because I'm actually pushing the back up there. This is a nice way to rule out your DVT. And then there's just things like muscle tears, but we won't go into that because it can be quite complicated looking at the muscle tears because you've got to get your orientation for your muscles right and interrogate them. I mean, you're only going to pick up probably 30% of tears in the soleus anyway. So it's mainly for sort of gastrocnemius muscle tears and things like that. Okay, just go back on your phone again, Abby. Just one more thing I wanted to go over. You can look for, so if you take the pen and knee right up as far as you can go, and then put your probe on top of the knee, you can see you get a nice, lovely, look at this sort of trachea, and you can look at the, so you can look at these edges here, so there's any sort of osteophytes here, you can look at the cartilage, and then go down to the other side and look at any irregularity there. So you can pick up gout here, so if they've got gout, you'll get some sort of like a uric acid crystal deposition along this sort of cartilage interface here. Or if it's CPPD, Fossa, I can't say that, it'll be more in the middle. Okay, so you'll get like deposition within the middle, and it's just like a tram line in the middle of the cartilage, but gout will be like on the surface here, on the cartilage interface here. And that was a very quick whistle-stop tour of the knee. Any questions there, Steve? Or have I sent everyone to sleep?
No, you haven't done that, but you've been very thorough. Thank you. And thank you for the reference to Zorro. I do appreciate it when you bring things to my level.
I see you smile as I mentioned.
This has come up before, of course, and I did ask the question last time Zorro got a mention. Trivia question for everyone. What was the name of Zorro's horse?
Oh, you did, you told me.
I've asked you this before. Anybody on chat and knows the answer, feel free. This is not as important as your presentation, of course. This is far more useful, but I do like a bit of trivia.
I do remember you saying that. I've forgotten. I'll put us out of misery.
See, I listen to every word you say. You don't listen to a word I say. Chris is coming with lightning. No, not lightning.
Lightning was
Vasily, I think there's a spelling mistake, but tornado. Vasily's come in with a tornado, but it was a tornado.
Tornado.
Vasily's part, but it was tornado.
Oh,
tornado was Zorro's horse. I'm showing my age. There's probably people out there thinking, what are they talking about? Who is Zorro? Anyone under the age of 40 probably has no idea what we're talking about. The best program on a Saturday morning for many a year.
Land of the Giants for me, Steve. My era.
No, but anyway, tornado. Yes, Vasily did mean tornado. So the prize goes to Vasily. So yeah, no actual questions though for you, Adrian, but I do think that was probably because you've been very thorough. That was brilliant, amazing as always.
It was fun. Yeah, it was fun to see. We've got a lot of really key little points in there. Really fabulous hints and tips. Hopefully, people picked up a little nugget or two this evening from Adrian.
Yeah. It'd be nice to get some feedback from the guys out there. One, did you enjoy that this evening? Two, if you are experienced in scanning, let us know. Or if you're new to scanning, just drop something on the chat there. It'd be nice to interact and get your thoughts coming in before we go. Did I jump in? You did finish by that? You had finished, hadn't you?
Yeah, sure.
I got sidetracked. I'm just checking. Sorry, before I go to finish things off. Was there anything else you wanted to add?
No, I've got maybe 2 or 3 images if you want to have a look at some.
Brilliant. That would be great. Let's do that. But I'll encourage everybody whilst he's doing that, whilst Adrian's doing that, do respond to my question then if you don't mind. Let us know a little bit about your scanning experience and some feedback on this evening would be really appreciated. But yeah, let's do that.
Who have we got watching this evening, Steve? We've got many chiropractors or physios or osteopaths or anybody else? Dentists, brain surgeons, whatever. It's all connected, isn't it?
Yeah, I think there's a good mix this evening. Chiropractors certainly, and I noticed 1 or 2 sports injury clinics, guys from 1 sports injury clinics with us. So quite a good mix, I think. Yeah. Again, that's a good question, Abby. Thank you. Everybody out there, if you'd like to tell us what you do, and as I say, with regards to your experience of scanning and what you are, so to speak, what your profession is, that would be great to get that input. I know Adrian and Abid really appreciate that feedback. They like to know who the audience is and what your experience is and what you've got from this evening. So please do interact with us on the chat. But yeah, I think there's a good mixed bag this evening, Abid. Yeah.
Good. Yes. Can you see that image, Steve?
I can. Well, I can see the thumbnail of it.
Oh.
The thumbnails I can see.
Okay. Why can't I? So you can see them in the box.
Yeah, see the box. You've ticked this first one, but it is not. Have you got to click it? Maybe.
Not full screen.
Not on full screen.
Hold on then. Maybe I need to. Oh, here we go. How's that?
That's it. Perfect. Thank you.
Okay.
There.
So I remember this from last time. Someone wanted to see if you could see a plicker, and this is what that looks like in the fluid. So if you've got a load of fluid around it, you can see it. But whether you pick this up without the fluid, I don't know. I don't think I would. Let's have a look.
Almost like a septum.
Yeah. So this is quadriceps tendon, and this is what sort of enthesophyte calcification within the quadriceps tendon looks like. So you get this little area here. I don't know, you can just make out some shadowing as it's shadowing those fibers underneath there, some shadowing there. And this is obviously, you can probably see the 2 layers here. So this is probably intermedius here, and then vastus lateralis and medialis, and then rec fem across the top here. So you can see that calcification in there. This is a quadriceps rupture here. So you can see that as the quadriceps comes across, the rec fem comes across, you can see whoop, there's a big dip here. Okay. And you can see that there's obviously loss of fibrillar pattern here and reduced in thickness. So this is actually the sort of retracted stump of the quads tendon here. A little bit of fluid here as well. This was this prepatellar bursa I was telling you about. So look here, look. So you've got a nice bursa here, and you've got a good standoff on the top. So any slight pressure that'll just be squashed down. It'll just look like this. You'd miss that. So the lightest of touches, get that standoff so you can see it, and then that part of that bursa, if it's there, will pop out. So this is the speech bubble you're looking for with the Baker's cyst. So they've got the medial head of gastroc, then you've got the semimembranosus, semimembranosus, and you've got this speech bubble of fluid, and that's characteristic, so you want to look for that. And that's all I had, I think. So just a few nuggets of things there.
Well, that's great. Thank you. Thanks for sharing those. Brilliant.
Okay. We need to go back to there.
Awesome. Great. Still no questions or comments coming in. Can only encourage people, if they'd like to, tell us about themselves and ask any questions they might have. Here we go from Sarah. Thanks for a great practical demo of a knee scan. This is my first webinar with you guys. A chiropractor colleague recommended you. That's great to hear. Thank you. I'm a sports therapist and been using MSK ultrasound as an added diagnostic tool in clinic for 4 years now and find it super fascinating. That's great to hear your feedback, Sarah. Thank you. Glad. Always nice to hear that you've come along on recommendation. So please do pass on the good word to anybody else that you think might be interested in joining us. So yeah, great to get that. Thank you. We try and do these as relatively regular. We did them very regular last year, right throughout lockdown. We were doing them pretty much once a week, then we slowed down to every other week, didn't we? But we're doing less frequently now because we've introduced the last couple of months, we've introduced some actual virtual mentor sessions modules that Adrian and Abid have kindly put together for us. So a lot of the time is taken up doing that. So that's where people subscribe and actually pay for. All these webinars typically that we do on a Wednesday evening are free. I'm really proud of what we've delivered from CelticSMR Healthcare with Adrian and Abid. They are two of the best as far as I know. I've called them Djokovic and Federer in the past. If you can imagine, you got two of the best right here, and if you can imagine Djokovic and Federer playing doubles together, that's what you get when you watch these guys learning and teaching you guys scanning. So we hope all of you out there that have joined us for the first time this evening have enjoyed it. It's always great to see new names or new faces, new people joining us. Please do follow us on Eventbrite so you can be aware of future events coming up. As I say, we try and do these quite regular, less regular at the moment, but nevertheless we try and keep some regular, deliver some regular webinars for you and some great content from the guys. So do follow us on Eventbrite. That's the best way of keeping up to speed with more coming up, and that you can get some more information on the mentor sessions that we deliver as well. And we're 1.5 in on those, aren't we, guys? And they're going really, really well. We're getting some great feedback from the guys that did the shoulder last month, and we're halfway through the 4 foot this month. Yeah, do follow us on that. Follow us as well, please, if you could, on Facebook, Twitter, Instagram, LinkedIn, all the usual forums. Slightly going off social media this week, if I'm honest, but nevertheless,
you do need a break every so often.
It does leave a bit of a sour taste in your mouth, doesn't it? But anyway, I'm digressing. Please do follow us on CelticSMR Healthcare social media, and like us when you can. We'd be very, very grateful. Okay.
Can I just say thanks to everybody who so far has been keeping up with our modules and has been kind enough to be doing the homework and sending in the images for us to have a look at. It's been really interesting and great to have the interaction. And so far, everything's been top notch. Everything that I've seen from those that are still training that they've sent through has been really high standard work. So testament to those that have spent the time and the effort and put the energy in, because of course, it's a practical skill. You've got to give it time and to get there. So thanks a bunch to all those guys that have been submitting their homework. So I am a little bit behind, but tomorrow I've got another hour or so. I'll be going through some further images, so expect some email replies from them. Nice.
Thanks, David. No, great. That's good to hear. That's great to hear. One or two bits of feedback coming in. Many thanks from Stuart. Thank you, Stuart. Thanks for joining us. Who we got? Stephen Wales. Evening all, I'm a chiropractor, so more familiar with x-rays. This was an interesting first look at ultrasound to consider looking at things from a different perspective. Thank you. That's great. Glad you got something from that, Stephen. Thank you very much. And we have got a request for link for modules. Yeah, we'll get that to you. Arjaz Fleet. I hope I've said that right. Apologies if I haven't. So yeah, we'll get those links to you. Thank you. With pleasure. Yeah, no, that's great. That's really great. I don't think we know when we're back next, do we? Don't think we've got anything in the diary, but I think it's safe to assume we'll be back next month. So encourage everybody to follow us, and we haven't got a date in the diary at the moment, but there'll be a date soon. If you go onto our website, let me do
a bit of a summer holiday, Steve. Or
sorry?
I thought that was because you were allowing us a summer holiday, or are you going to continue to prep the week through August as well?
I'd forgotten that. You caught me on a weak moment, didn't you? Yeah, we're having a holiday like next month. You're absolutely right. I'd forgotten. You're absolutely right. So you won't see us next month, everybody. Apologies for that. Quite right. We're gonna have a summer break. Let me so just a very quick commercial break in a sense, but actually not so much from a commercial point of view. Can you see my screen? Okay. Can you see?
Yeah, receiving.
I just want to, those of you who have joined us for the first time this evening, if you go, this is our website, CelticSMR, and we do veterinary and we do healthcare. So obviously we're most interested in the healthcare side of things over here. But if you go here, there's this banner, Healthcare CPD. If you click into there, I said a few moments ago that we've been delivering some amazing content from Djokovic and Federer, as I prefer to call them, Adrian and Avid. Go way back, and you can see the content. Yeah, you can just pick and choose what might be of most interest to you. I think when we're back in September, it's coming back to me now, we are covering the elbow, which has just prompted me there seeing that one. So there's all this content here. Go through, it's all free, it's all available. Go in, have a look. Some of them are 45 minutes long, some are long, an hour and 20 minutes. It's so much content there for you to go and have a look. You've had a taste of what Adrian delivers this evening, and there's all those hours of catching up there for you. All there. We've added some of the more recent ones as well. We've added onto our YouTube channel. So, but if you go here, you'll find us and you'll get lots of information. There's a little bit about my guys, Abid and Adrian. A little bit about those guys, and if you keep going down, we actually do class 4 laser therapy as well. So we've been delivering, when we've not been doing webinars on the scanning, we've been delivering webinars on the class 4 laser therapies as well. So much content there for you to go and have a look. If you do want a little bit more information about our products, this is what we do. So say if you go to the healthcare section, as I just mentioned, we do the class 4 laser therapy. And you go in there and you can see the products. I'm just going to show that very briefly, but I'll come out because obviously you're here for the scanning this evening, so that's the scanning products might be of more interest to you. We do a range called Sonoscape. We're the UK distributors for the Sonoscape, and there is the family of scanners, starting from E1, the portable through to S9. And the cart based here, which is what Adrian's been using this evening. We use the cart based ones because we want to get the best image through the screens to you guys, but we're getting amazing feedback from more and more people all the time. Our growing family of Sonoscape users in the UK, the E2 X3 are proving so popular, or more than adequate for MSK work. We tend to suggest the E2 upwards because it has the color Doppler. The E1 is a great scanner itself, but it doesn't have the color Doppler, which is a bit restrictive for MSK work typically. So I always say the entry level is the E1, but that's a bit disingenuous when we're talking to people about MSK scanning. You really need an E2 upwards, but the good news is the E2, our entry level, if you will, for MSK is proving so popular, and it's at a really good price point that makes it very competitive to other scanners out there on the market. So if you are looking to invest in a scanner at some point, please do have a look at ours. We can offer up a demonstration and a trial of the units at a time that's convenient for you. So that's the range of scan, and then go through. The more experienced you are at scanning, then you can go right through to the top end range of scanners, all still portable as well, or to the cart based, as I say. So from our Sonoscape family of scanners, there's quite a good choice to meet your needs and your budget, quite frankly. So that's us. That's a little bit about us. But as I say, main thing to remind you to mention to you is go into the healthcare CPD and all this free content. See what Adrian and Abid can tell you about different aspects of scanning. So we've got, as I say, pick the topic of most interest to you, and away you go. And do let us know if you've watched it and feedback. There you go. I'm back. That was me. Thank you for listening to it. I don't think I normally, when I start talking, we normally lose people, but I started talking with 25 participants and we still got 25, so that's good. Thank you for everybody sticking around. Thank you very much indeed to Adrian and Abid. Really grateful. Absolute pleasure every time. Really grateful for your giving up your time. And so just leaves me to say get home safe to your beautiful families, and we'll see you soon.
Thanks, Steve, and thanks for giving up your time, because you're actually supposed to be on holiday today. I don't know if the audience are aware, so thanks for your staunch, heroic support that you give us every single time. Much appreciated.
Absolute pleasure. Thank you.